I promised, we are back. So, without wasting time, I want to call on the next presenter on the topic current trend and advances in clinical pharmacokinetics. So, without wasting time, please, with the round of applause, let us welcome the next presenter. You're welcome. Thank you very much. All right.
Good day, everyone. I'm Ezekiel Kikelomo Renike. I'll be talking on the current trend and advances on clinical pharmacokinetics. You already know pharmacology is diversifying into pharmacokinetics and pharmacodynamics, in which pharmacokinetics study the absorption, distribution, metabolism, and elimination of drug from the body. And pharmacodynamics is what the drug does to the body. But now we are going to the current trend and advances in clinical pharmacokinetics. Clinical pharmacokinetics is the study of how drug move through the body over time with the goal of optimizing drug therapy for individual patients. But now it's focusing on the absorption, the distribution, the metabolism, and elimination of drug from the body. There are numbers of areas in which advances have been made over the last few years in the area of clinical pharmacokinetics in the elderly. Now we are moving to the aspect of the elderly. There is increasing understanding of diversities of cytochrome P450 and the variability of the age-related decline in cytochrome P450 activity. We already know cytochrome P450 is an enzyme in the liver that help to metabolize drug. This has helped to explain some of the individual variability in drug metabolism with age. Genetics also talk about how the variability of drug does in different people, same drug effect on different people, and also the metabolism too with the elderly. The importance of this ethic difference has emerged, but specific work is needed in this area in the elderly. Differences in the handling of chiral compound has been reported, but has yet to be clinical effective. The emerging importance of cytochrome P450 in the elderly, especially in the intestine, has added a new complexity to our understanding of pharmacokinetics, but whether it will be of value or not. What they can tell us here is that the way this current trend has give us a better understanding on how drug is being metabolized in elderly. It's different from a young adult like me and different from the infants or the neonates. Recent data has supported its potential use to define those more at risk at clinical meaningful pharmacokinetics alteration. Other advances have included the approach that selectivity in the induction and inhibition in the elderly are due to existence of multiple cytochrome P450 form. So now, one of the current trends in clinical pharmacokinetics is application of artificial intelligence. Artificial intelligence has revolutionized healthcare and clinical pharmacokinetics. This helps to share more light on the diverse application of AI in pharmacology research and clinical pharmacokinetics. AI machine learning models have been creatively applied in clinical pharmacokinetics variety of contents. Unsupervised cluster method, for example, have demonstrated promise in locating protective medical substance and identifying patient groups who are well suited for particular therapies. Techniques have also proven useful in improving therapeutic medication monitoring. Drug levels in patient system are analyzed to maximize therapeutic efficacy while minimizing side effects. So one of the artificial intelligence is natural language processing. Is an important area where artificial intelligence has advanced significantly. It's increasingly being used to mine electronic health record for useful real-world data. This method has enabled researchers to comprehend medication safety and efficacy profiles across a wide range of patient population beyond restricted scope of controlled clinical studies. It particularly emphasizes AI's ability to manage large database. This AI is used to in a very large is used to access a very large database, learn, adapt, which pave the way for novel advancement in patient care and drug development. AI roles range from predicting the drug interaction to tailoring medication dosage for individual patients, demonstrating its extensive contribution to the field. These reports underscores AI capacity to significantly enhance the efficacy and safety of pharmaceutical service. Furthermore, the integration of this generative AI into pharmacokinetics marks a significant shift in healthcare, promising more efficient, effective, and precisely tailored treatment. This advancement is not only about enhancing safety and efficacy, it is also reshaping the landscape of drug development and patient care into more informed and patient-centered approach. This AI-driven evolution in healthcare has the potential to reduce the number of subjects needed in clinical trials by enabling more precise methodology with higher efficacy. AI can minimize the required sample size, thereby significantly cutting costs and shortening the duration of trials. We also have the integration of macroeconomics as part of the current trend in clinical pharmacokinetics. Clinical pharmacokinetics now increasingly incorporates genetic testing to personalize therapy. Pharmacoeconomics in clinical pharmacokinetics represents a progressive shift in healthcare decision making aimed at optimizing both therapeutic outcome and resource utilization. Clinical pharmacokinetics focus on the individualization of drug dosing based on absorption, distribution, metabolism, and excretion characteristics. When combined with pharmacoeconomics principles, this integration supports cost-effective, evidence-based treatment strategies tailored to patient-specific needs. One key area in this integration of pharmacoeconomics is model-informed prescription dosing, which uses pharmacokinetics model to optimize drug dosing in real time. While the MIPD, which is the model-informed precision dosing, improve clinical outcomes, it may improve higher initial costs due to specialized software and monitoring. Macroeconomics evaluations such as cost effectiveness analysis help to determine whether a long-term benefit outweigh those upfront expenses. We also have therapeutic drug monitoring under integration of pharmacoeconomics. This therapeutic drug monitoring is used especially for drugs with narrow therapeutic windows like vancomycin or aminoglycoside. Pharmacokinetics is essential to maintain drug concentration within safe and effective limits, incorporating pharmacoeconomics analysis justifying the cost of therapeutic drug monitoring service by demonstrating reduced toxicity related cost and improved patient outcome. We also have health technology assessments under that same integration of pharmacoeconomics. This body increasingly consider pharmacokinetic data and pharmacoeconomics outcomes in reimbursement decision. For example, cost utility analysis involving quality adjustment life years may use pharmacokinetic modeling to estimate the duration and quality of therapeutic benefit. Integrating pharmacoeconomics into clinical pharmacokinetics enhances patient care by aligning individualized therapy with economic sustainability. This approach ensures the rational use of healthcare resources while maintaining high standard of safety and efficacy. So this integration of macroeconomics is talking more about the cost effectiveness, not only the effectiveness of the drug itself now, but it's talking about the cost effectiveness and maintaining high standard of safety and efficacy of which as a new trend of clinical pharmacokinetics. Now to the reward data. The incorporation of reward data is an emerging and impactful trend in clinical pharmacokinetics. Traditionally, pharmacokinetic data were derived from controlled clinical trials involved selected patient population. While these trials provide high-quality data, they often lack diversity and complexity seen in routine clinical practice. This RWD, which is real-world data, obtained from sources such as electronic health record, insurance claim, patient registries, and mobile health devices. They bridge this gap by offering insights on how drugs behave across broader and more heterogeneous population. In clinical pharmacokinetics, it helps to understand drug exposure variability in real-life setting and assess the impact of factors age, weight, renal function, polypharmacy, and so on. Like I've said earlier, that pharmacokinetics on its own is deal with the absorption, the metabolism, and expression of drug, while incorporating the clinical pharmacokinetics, while merging the clinical aspect and pharmacokinetics together is focusing on the admin, which is the absorption, distribution, metabolism, and elimination of drug in the body, alongside with pharmacodynamics, which is what the drug does to the body, which is you achieving a effective therapeutic effect of the drug that is being ingested. So additionally, regulatory agency like FDA, that's Food Drug Administration, increasingly recognize RDW in evaluating drug safety, effectiveness, and optimal use. For example, RWD analysis have been used to adjust dosing recommendation for drug like vancomycin and carbapenems in critical ill patients. So another focus is on special population in clinical pharmacokinetics. Special population, I mean, I'm talking about the neonates, the elderly, the pregnant women, the obese patients, and critical ill patients. If I'm taking a drug, it will the same drug on different body, like the way the drug will work on an elderly or a critical ill patient or a neonate is different, because the way our body system, the genetics, the sex, the age, how they react to drugs are different. So now to the neonate. In neonate and pediatric patients, neonate, that's 0 to 24 days old, of a newborn baby, that's within the range of 0 to 24 days. Enzyme system involved in drug metabolism are immature, leading to a slower drug clearance and a long half-life. The way the drug will be cleared from a neonate is different from the way the drug will be cleared from someone like me, because their body system is not yet matured to the normal level that it's how to metabolize or distribute the drug to their body. And even the half-life too will be different. You already know that half-life is when the drug you take, the time interval for the drug to reduce back to half of its initial value. For example, aminoglycoside require extended dosing intervals in neonates due to the reduced renal function. Their kidney that is to metabolize the drug, and their liver that is supposed to metabolize the drug, and their kidney that will excrete the drug is different from how it will be excreted in my own body system. So, for example, aminoglycoside require extended dosing interval in neonates due to reduced renal function. Their renal system is not yet matured enough. In contrast, children may require high weight-based doses due to faster metabolism compared to adults. So now to the pregnancy women. Present another challenge as a psychological changes such as increased blood volume, altered gastrointestinal motility, and enhanced renal clearance can significantly alter drug levels. What I'm trying to tell us here is that due to the fact that these ladies are pregnant, the way they will react to the drugs too will be different, and there will be a significant alteration from the clearance of the drug from their body. Anti-epileptic drug like lamotrigine often need dose adjustment throughout pregnancy to maintain therapeutic value. That's for pregnant women that have epilepsy. And for the elderly, there are some changes in elderly that it can be also as well linked to the children, because I think they have the same body system. Frequently, In the elderly, frequently used have been decreased renal and hepatic function, changes in body fat and water composition, and are often on multiple medication, increasing the risk of drug interaction. In obese patients, changes in the body composition and organ size affect drug distribution and clearance. In the obese patients, they have a big body weight, so there is a changes in the organ size and it affects the volume of distribution of drug and the clearance in their body. And for the critical ill patients too, they often exhibit unpredictable PK behavior due to organ dysfunction, fluid shifts, and inflammation. Individualized dosing guided by therapeutic drug monitoring and population models is essential. So now to the advances in the clinical pharmacokinetics. We have modern informed drug development as an advances in clinical pharmacokinetics. This modern drug development represents a significant advancement in clinical pharmacokinetics and regulatory science. It refers to the use of quantitative models to integrate drug, disease, and patient data to inform decision making throughout the drug process. This model include pharmacokinetics, pharmacodynamic, physiological based pharmacokinetics, and exposure response models, which together guide those selection and onto a new generation anti-epileptic drug as part of the advances. Epilepsy occurs across entire age range and their incidence peaks in the first year of life and in elderly. Therefore, anti-epileptic drugs are commonly used at the extremes of age. Rational prescribing in these age groups require not only an understanding of drug pharmacokinetic property, but also careful consideration of potential age-related changes in their pharmacokinetic profile. Neonates, infants, children, and elderly. There has been a present article which updates a review published in 2006 in the journal that focuses recently on the pharmacokinetics of new generation regarding epilepsy people. Significant new information on the pharmacokinetics of this AED in the peritennial period has been acquired, particularly for lamotrigine and levetiracetam. As a result of slow maturation of enzyme involved in the glucuride conjugation, lamotrigine elimination occurs at a particular slow rate in neonates and becomes gradually more efficient during the first months of life. That's for those that have epilepsy. In the case of levetiracetam, elimination occurs primarily by renal excretion and is also slow at birth, but drug clearance increases rapidly thereby and can be doubled within a week. In general, infants older than 2 to 3 months and children show higher drug clearance to this epilepsy drug. So we also have a typical antipsychotic as part of the advances that has been made in clinical pharmacokinetic. In the past, the information about those clinical effectiveness of typical antipsychotic was not complete, and this led to the risk of extrapyramidal adverse effects. Together with the intention of improving patient quality of life and therapeutic compliance, resulted in development of atypical or second generation of antipsychotic. This review will concentrate on pharmacokinetics and metabolism of antipsychotic drugs like risperidone, olanzapine, and clozapine. But time is not by my side. So down to the conclusion, the field that we now call clinical pharmacokinetics started many decades ago to achieve a quantitative understanding of time course of drug action and the factors that might influence dose taking and intensity of drug effect. The motivation of this was to gain the information needed to solve renal and important clinical problems. Problems of this nature will continue to appear with both new and old drug. In addition, new kind of problem related to movement of drug molecules within and throughout human are of major clinical importance. Solving them will require continued progress and research in clinical pharmacokinetics. Thank you.
Wow, wow, wow. Wow, thank you very much. I don't know, I don't know, I don't know, I don't know, I don't know. Are you proud of yourself now? Yes. Yes, I don't know, I don't know. That was awesome. That was awesome. That was awesome. Thank you very much for the presentation, talking about the the current trend in what? Clinical what? Pharmacokinetics. Is a very, very wonderful and a very great aspect of pharmacy that has a very important um, role, that play a very important role in therapy. Clinical pharmacokinetics. All right, without wasting time, I'm not here to start the lecture all over again. Without wasting time, I want to go for now, but please do not think of, do not even imagine leaving that to your desk or dropping that to your phone, because we are coming back again with another awesome, I don't know how to put it, breathtaking presentation. And God will bless you as you wait for us.